Welcome to The Explainer. Today, we are diving deep into post-traumatic stress disorder, or PTSD. We're going to be looking at a really important 2025 review from World Psychiatry. So we'll kick things off by exploring how the very definition of PTSD has shifted and what the latest data from around the globe reveals about who's really most at risk.
Okay, so to really get a handle on PTSD, you've got to step back and look at the bigger picture. We need to understand just how widespread trauma is in our world right now. And, this isn't some niche problem. It's become a huge challenge for public health everywhere.
And honestly, the numbers are pretty staggering. Right now, the world is seeing more state-based conflicts than at any time since World War II. Think about that. We're talking about 468 million children living in conflict zones. But it doesn't stop there. We're also facing these new, ever-present stressors, things like climate change, domestic abuse, even trauma in the workplace. Because of all this, managing trauma has gone from being a specialized field to something that's absolutely central to how we think about global health.
So that begs the question, right? What exactly is a traumatic event? It seems like a simple question, but the answer has actually changed a lot over the years. It's gotten way more nuanced.
The old way of thinking was that a trauma was something that would distress almost anyone, but we've moved past that. The model we use now, what you see here called the gatekeeper definition, is different. It's about identifying stressors that have the potential to overwhelm some people. That's a huge shift because it recognizes that we're all different. It also opens the door to including things like indirect or repeated exposure. The kind of thing first responders deal with all the time.
And that brings us to our modern, much more precise definition. A traumatic event is something that has the potential to severely challenge the ability of a person or even a whole community to adapt. That word, potential, is everything. It's the possibility of being overwhelmed, forcing major changes in how you live or think that really defines it.
Okay, this is where it gets really interesting. How do we actually diagnose this? Well, the world's two main diagnostic manuals, the DSM and the ICD, have gone in completely different directions. They have fundamentally different philosophies about what PTSD is.
So on one hand, you've got the DSM-5 from the American Psychiatric Association. You can think of it like they're casting a really broad net. The goal is high sensitivity, to catch as many potential cases as possible. Then, on the other hand, you have the World Health Organization's ICD-11. They take what's called a core pathology approach. It's all about high specificity, zeroing in on a much more tightly defined group of symptoms. Let's dig into the DSM-5's approach first. It lists 20 different symptoms, and they're grouped into 4 clusters. You've got intrusion, avoidance, negative changes in cognition and mood, and finally, alterations in arousal. Because this net is so wide, it leads to a higher prevalence estimate, about 8.3% in the US. The downside, you get a lot of overlap, what we call comorbidity, with other conditions like depression and anxiety. Now, the ICD-11 is a totally different story. It simplifies things way down to just 3 core symptom clusters: re-experiencing the trauma right here, right now, deliberately avoiding reminders, and a constant sense of threat. But here's the absolute key difference. The ICD-11 says these symptoms must cause significant functional impairment. You have to show it's messing up your life. And because that bar is higher, you naturally get a lower prevalence estimate. So, why does all this matter? It's not just an academic debate. These different ways of looking at PTSD lead to identifying very different subtypes or phenotypes of the disorder. And that has huge real-world consequences for how we treat it. So within the DSM-5 world, there's this really important subtype called the dissociative subtype. It shows up in about 10 to 30% of PTSD cases. This is where people experience things like depersonalization. That's a feeling of being detached from yourself, like you're watching a movie of your life. Or derealization, where the world around you feels unreal or foggy. What's crucial here is that this subtype is often linked to early childhood trauma, and unfortunately, it doesn't respond as well to our standard therapies. Now, the big game changer in the ICD-11 is a whole new diagnosis, complex PTSD, or CPTSD. And let's be clear, this is not just a subtype, it's its own thing. To get this diagnosis, you have to meet the criteria for regular PTSD, plus you have to have these long-term problems with what they call disturbances in self-organization. This basically means serious trouble with emotional regulation, problems with relationships, and this deep, negative sense of self. And the evidence for this is just crystal clear. Studies from all over the world have found these two distinct groups of patients. You have the PTSD group, who have all the core symptoms but low levels of those disturbances in self-organization, or DSO. Then you have the CPTSD group, who are high in both the core symptoms and DSO. This is powerful stuff because it proves CPTSD isn't just bad PTSD. No, it's a completely different clinical entity, and it's almost always tied to long-term early life trauma, things like ongoing childhood abuse or torture. All right, let's do a quick recap of the two systems. Think of the DSM-5 as a lumper. It's broader, has 20 symptoms, and it pulls in that dissociative subtype. The ICD-11, on the other hand, is a splitter. It's way more specific, with just 6 core symptoms, and it carves out complex PTSD as a whole separate diagnosis. The result? The DSM-5 has more messy overlap with other conditions, while the ICD-11 is a bit cleaner. Okay, so we've got the theory down, but what does this actually look like out in the real world? Let's dive into the epidemiology and see who's getting PTSD, where, and what factors really crank up the risk. Just look at this map. The prevalence rates are all over the place, right? You see numbers around 8% in the US, but then it drops to just 0.4% in China. But, and this is a really big but, we have to be careful about how we get these numbers. We've learned from the World Mental Health Surveys that if you just ask people about their worst trauma, you can actually inflate the rates. A better way, called the random event method, gives us a more realistic global average, something closer to 3.9%. And this is absolutely critical. Not all traumas are created equal. Not even close. What this chart shows is the probability of getting PTSD if you're exposed to a certain kind of trauma. And look at that difference. The risk from intentional violence, like rape or assault, is just orders of magnitude higher than from something like an accident or a natural disaster.
And that all comes down to this one key concept: intentionality. Basically, it's about whether the harm was caused on purpose by another person. When another human being hurts you, it just shatters your basic assumptions about the world, about safety, about trust, in a way that a random accident or a hurricane just doesn't. And that is a huge driver of risk for PTSD.
Of course, your culture plays a huge role in this too. In a lot of collectivist cultures, you have this idea of I am because we are. The line between you and your community is much more fluid. So when something traumatic happens to the community, it's felt as a personal trauma. This really helps us understand why studies in places like South Africa and Japan find such high rates of PTSD just from witnessing something terrible happen to your group.
And then there's one more piece to this puzzle: moral injury. Now, this isn't about being scared. This is about having your own moral code violated, a betrayal of what you believe is right. The driving emotions here are things like deep shame, guilt, and just this feeling of being mentally defeated. We're finding this is a really powerful predictor of PTSD, especially for people like soldiers or doctors who are put in these impossible ethical situations. Wow, we've covered a ton of ground here, from how we diagnose PTSD to who gets it and why. So let's take a second and boil it all down to the most important takeaways from part 1.
All right, here's what you really need to remember. First, how we diagnose PTSD has totally changed. We've moved beyond just thinking about a single event, and now we recognize these complex forms, like the dissociative subtype and complex PTSD. Second, and this is important, these aren't just slightly different flavors of PTSD, they are clinically distinct groups. Third, the numbers show that who gets PTSD is massively influenced by culture and whether the trauma was intentional. And finally, what does this all mean? It means the biggest challenge we face is that PTSD is incredibly varied. It's not one size fits all, and we desperately need a more personalized approach. So all of this leaves us with a really big question, and it's the perfect setup for part 2. How do these diagnostic differences, this whole lumper versus splitter debate, actually connect to what's happening in the brain? And, maybe most importantly, how can we use this knowledge to create treatments that actually work for the right person? That's what we'll get into next time. Hope you'll join us.